I'm Dr. Valmor Semide, and I would like to introduce the speaker this afternoon. Is Dr. Ramzi Al-Judaibi. He's a Saudi board certified ophthalmologist who has training here at King Khalid Eye Specialist Hospital. He has a vitreoretinal surgical fellowship as well as a research fellowship. And he's a cherished member of our division. And he will be speaking to us this afternoon about tips and tricks in scleral buckling as a single procedure. So Ramzi, if you're kind enough to begin.
Okay, thank you. So everybody's sharing my screen?
Yes.
Okay.
Yes.
Thank you. I will talk about scleral buckle as a single procedure in a matter of treating rheumatogenic retinal detachment. As introduction, this procedure is an old procedure, started in 50s, and it was a really highly successful procedure to treating the rheumatogenic retinal detachment. And the fundamental goal for the buckling is the closure of all retinal breaks. And it helps and it goes for this goal by reduce the vitreoretinal traction, simply it displacing the eye wall toward the retina. And also by this displacement, it pushes the subretinal fluid away from the detached zone, so that approximating more and causing some fluid turbulence that this fluid turbulence facilitate to push the subretinal fluid away and ensure more healing. Also, they approximate the vitreous gel to the retinal breaks. All these mechanisms works in a matter of pushing away all the subretinal fluid and approximating the retinal break to the ocular wall. And with cryotherapy, it induces an adhesion, and so this break will close, and fibrosis will be formed, and the retina will be flat. How is success the scleral buckle as a single procedure without any other procedure? There is a study, scleral buckling versus primary vitrectomy in rheumatogenic retinal detachment. It is randomized prospective multicenter study, and they divide the patient into three categories: phakic group and pseudophakic and aphakic group. As a result, for the phakic group, those patients, they are treated by only scleral buckle. They have the best visual acuity, and they have less progression of cataract, and they require less secondary step. And for the other groups, the pseudophakic and aphakic group, they share the same final visual acuity with the pars plana vitrectomy, but those patients, they have higher rate of need for another step. So in phakic group, they have better visual acuity, and in pseudophakic and aphakic group, they have similar visual acuity, but they may need for another step. Other studies shows that scleral buckle is superior in the following conditions. So these conditions have a better outcome on scleral buckling: phakic patients, young patient with attached hyaloid, retina dialysis, and phakic patient with inferior detachment. How popular is scleral buckle in the today practice? The American Society of Retina Specialists, they did a survey, and they asked the retina specialists around the world in what percentage they use scleral buckling as a management for rheumatogenic retinal detachment. And the choice from 0 to 10% of your practice was selected by 28% of the retina surgeon in the United States and almost 40% in Europe. So almost 1/3 or more of retina specialists who participate in this survey, they use buckle maximally on 10% or they never use it at all. So why, despite this really good success rate for the scleral buckle, why it is not being widely used today? There are many factors like great advancement in pars plana vitrectomy. Now pars plana vitrectomy is really greatly being invested by bigger companies and going for great advancement, and better visualization also give an extra advantage on scleral buckling. And buckle, honestly, is a cheap procedure. It costs less, and it is maybe less profitable for major companies. One more reason regarding the surgeon itself, that trainee may feel less comfortable with buckle compared to pars plana vitrectomy, because it needs some specific skills regarding the indirect examination and indentation, and especially for the visualization. Trainee, when sit on the microscope, they can see exactly what the primary surgeon is doing, but in classic scleral buckling, it is not the story. So they need to imagine and they need to go and examine by themselves. So the learning curve is a little bit slower. I always say to my colleagues that if you are a hunter and you want to go to the jungle to hunt, you cannot go with only one weapon. Okay, because there is a wide variety of things that you can hunt there, of animals. But if you have different tools in your hand, different types of guns, knives, arrows, whatever, and you have a good visualization as well, and you are really prepared, you will have a wide variety of options to manage your condition. Exactly the same condition for scleral buckling. If you have only vitrectomy as a choice for surgery for your patient, you will have a limited choice, especially that the retina cases are really widely variant from each other. But if you have scleral buckle as an option, you will increase your success rate for your cases. So how to achieve the best buckle success rate as a surgeon? Careful patient selection is very important. So those patients, as we mentioned before, they have higher, better success rate, like those patients, phakic patient, young patient without vitreous detachment, inferior breaks. Those are better to go for scleral buckle rather than pars plana vitrectomy. And also buckle selection. Buckle is not a single tool. There is a wide variety of buckle types and buckle techniques as well, and we will look through this. And it is not only one size fitting all techniques. It is custom made. You can tell based on your tear and your patient condition. And when it's used in an appropriate way, it is a very simple and highly effective technique. So let's have some tips and tricks how to achieve this. Success buckle doesn't start in OR. Success buckle starts in the clinic. It starts in the ER at the time of patient, first time for patient examination in the ER room or in the office. Preoperative assessment is very essential. Use indirect ophthalmoscope. Use indentation. That will give you a better judgment about which procedure is better. After you examine, just draw it. Either you draw it on the paper, on the file, or you draw it in your mind. Okay, draw it and copy it and decide how is the pathology is going and how to approach it. In this case, like there is a break in this 2 o'clock and with lattice around it from extending on the superior retina. See, this will give you a clue how things will be approached. And then ask yourself, does this pathology looks in the exam match Linkoff's rule? Because your game is to find the break and to close it. So if it doesn't match, that you may miss something and you need to go again and examine again. Because if you, one of the causes of failure of Scleral Buckle, if you miss a small break that not being managed. So again, which cases we prefer to go for Scleral Buckle if we examine our patient? Those patients for non-BVDs, kids and young age patient with retinal dialysis, and single anterior pathology. Which patients are preferred for pars plana vitrectomy? Zodophakia, patients they have already BVD, and patients with posterior pathology where buckle cannot reach. Multiple pathology also can be treated with vitrectomy, and poor visualization due to vitreous haze, pigmentation, vitreous hemorrhage, etc. Okay, what about chronicity and BVR? Is buckle effective against chronic retinal detachment and patient presented with BVR? There is a very nice article I refer you to done by our colleagues in King Khalid Specialist Hospital by Dr. Yahya Zahrani and his team. And they select cases for only chronic retinal detachment more than 3 months, and with evidence of BVR at the time of the diagnosis, and they follow up the patients for 1 year. And actually, it is a retrospective study. And the result, they found that anatomical outcome, Scleral Buckle gave the better as a single procedure. And for visual outcome, Scleral Buckle and pars plana vitrectomy, they have the same outcome. So actually, Scleral Buckle have a superior hand on these cases, and there is no inferiority in compared to pars plana vitrectomy. Then we'll go to the OR. In OR, if you cannot examine the patient in the clinic in a good way, or they are kids or young patients sometimes is not feeling comfort with indentation, do examination under anesthesia. I usually do this, and I examine the patient under GA, then I can decide which procedure is preferred for my patient. And plan your surgery based on this exam, and then you can go to use the proper tool. You know that if you want to repair something, usually there is a tool, and tool come in different size, different shapes, and for different in use. The same as buckle. Imagine all these are kinds of scleral buckling. Sponge, silicone bands, different size, different shapes. You can tell any one of them according to your need and your pathology that you want to manage. Visualization is very important. You need to examine 360. And if you have cornea or vitreous haze, you need to think again what procedure you will select. Indirect ophthalmoscope skills is very important. But now, if you have an option to use a microscope, you can use chandelier assistant pars plana vitrectomy. Then in localization, now you have a job to treat and to repair this retinal detachment. First of all, you need to have a good visualization to see where is your break. Then you need to localize it, then to treat it. So you need to localize it. If you have 1 or 2 breaks, just you need to mark it from the scleral side by the corner, and you may use also marking pen and measure it, so you can treat it with cryotherapy. And if you have retinal dialysis, just you need to mark it from the beginning and the end and the posterior border of the retinal dialysis. Also, give your attention that due to parallax effect, when you examine by the indirect ophthalmoscope, when you see a break with subretinal fluid, usually the breaks is a little bit anterior to the point that you see it on. So you need to depress well to flatten the retina on the sclera to have a proper size, to a proper localization of your break. Otherwise, you may fix the buckle in its place. So it may be a little bit posterior to your break, and this will push fluid more anterior, or you miss it and you put the buckle just anterior to your break. And then you can select the proper buckle for your case. Either you can use, for example, radial buckle, like in this case. This is a radial buckle. You can use it when the break is in the quadrant between the recti muscle. And this is from interior, and you see here is the radial buckle, and it's covering the fish mouth horseshoe tear. Or you can use it as circumferential, like silicone band. And you can even, if the silicone band is small, you can use a segment of larger size of silicone band that you can fix it on top of it. Drain if you need, as we mentioned, to better localize. Sometimes retinal fluid will be very high, will give you misapproach, or you cannot cryo because of the large level of subretinal fluid. Then you can drain the subretinal fluid if you need. This is our example from my clinic. This patient, she's a young female with peripheral pathology, and she had a superior horseshoe tear. And it is really a little bit posterior. I remember maybe it is around 15 or 16 millimeter from the limbus. So I put her on a circulating band, then I put on radial buckle, and the break was flat, and the subretinal fluid resolved, and the RD resolved. And this is another case. This is a young male with inferior chronic retinal detachment. The break is here. And I did for him circumferential 240 size band. And this is my cryo site. And you can see its retina become flat after the surgery. So take home message, Scleral Buckle is very useful, highly effective procedure, and very high success rate if selected in a proper way. This is my brief talk, and I have a clear message to deliver to the audience. Thank you for your attention.
Thank you, Ramzi. Thank you for that nice presentation. Now, it's very clear, and as you mentioned in the summary, that scleral buckling is an old technique, actually. But if the patients are selected properly, then we can enjoy very high success rates. But I also think that scleral buckling lately, it has also advantage from it has benefited from all the other advances that vitreoretinal surgery has to offer. For example, nowadays there's this tendency to do chandelier assisted buckles. This is something that in the old days, they couldn't do. It had to be done with an indirect. What's your opinion? Do you have a preference between chandelier buckles or the traditional indirect buckle with cryo?
It's according to the surgeon preference. So for me, I prefer chandelier assistant because we are in a training center. So the trainee will see exactly what the primary surgeon is doing in the same time. And this is really a great advantage. The disadvantage is that you need to open the vitreous cavity. But honestly, in classic buckle with indirect ophthalmoscope, after we tight the buckle, we usually do paracentesis, AC paracentesis, to deflate the AC and reduce the intraocular pressure. So for me, it doesn't have a big issue to fix a chandelier light and to gain the great advantage of better visualization under the microscope and give the same chance for the trainee to have the same vision.
Yeah, I have to agree with you 100%. For teaching purposes, it is ideal. And that argument of opening of turning or converting the extraocular surgery into an intraocular procedure once you open a chandelier port, I don't think it's justified. Like you mentioned, you have to do paracentesis in some cases. Some cases you will have to do external drainage of the subretinal fluid. So it kind of it's not justified to me. I also have encountered the issue that it can be uncomfortable when you're in the OR and you're doing your buckle and you're scrubbed the entire surgical field is sterile, and then you have to try to adjust with baggies the indirect over your head, or you're getting indirect lenses, the 30 or 20 diopter lens. And sometimes they can be damaged with the the sterilization process. So your view is really not that clear. On the other hand, there could also be vitreous pigment or vitreous hemorrhage that could really make it difficult to use the indirect. Another question that something that's very modern and a lot of people are doing in regards to how you fix the buckle onto the sclera. Traditionally, we suture the sclera onto the buckle onto the sclera, but more recently people have begun to do scleral tunnels with crescent blades. What's your take on that, and what's your preference? What do you feel?
I prefer to use the classic way, and I'm suturing all my buckles at the moment. I'm not in favor of doing scleral tunnel and for the purpose of sutureless buckle. I think it's more invasive rather than suturing. Suturing is brief, fast, and less invasive for the tissue. And also, those patients with retinal detachment, some of them, they are very high myope. And those patients, they have also a very thin sclera, and you want to create a scleral tunnel in this thin sclera is really difficult. I don't like it. I don't like it. I prefer to do the classic way, and I'm suturing all my buckles.
Okay, that's understandable. I have to agree with you in that sense as well. I don't know if we have any questions from any members of the audience. I don't know if there's any in the chat. Let me check. Does anybody have any question to add or any comment? Okay, one last thing, Ramzi, that I like telling the fellows is that sometimes we see the buckle as an additional step or a long, complex step in the surgery, but it's not. It's actually, once you've practiced it and you've done a few buckles, it can be very easy. And these fellows that are in training, they have the opportunity of being exposed to a wide variety of surgeons. They go through their training through 10, 12 different surgeons, as well as all the videos that they might watch on YouTube. So I think the best is to pick to cherry pick all the best parts or the best steps from each one of the surgeons that they're exposed to, and they can build their own their own technique. I certainly don't do the same buckle that I was trained to do in my fellowship. I do a completely different way, but you get this as you go on. It's definitely a useful tool that we can have.
Yeah, definitely. And also that the aim is the same and the objective is the same, but the technique maybe are a little bit different from one hand to another. But at the end, the goal is the same and the concept of the surgery is the same.
Yeah. And what's your take on using the microscope versus doing it with loupes, or just without a microscope, just with the spotlights on the field? Do you have a preference?
With microscope is much better and less stressful on the back, on the neck, and faster even. You can do it in a faster way. Yeah, disadvantage if you open the vitreous cavity, I understand, but at the end, it's really very comfort for the surgeon.
Absolutely. I on the other hand prefer doing them with the spotlights. I feel you have more. You're not you know, you have to move your hands around the field in order to be able to address each of the different quadrants. And sometimes with a microscope, I feel like I have a limitation to all that movement. But that's just me. So I don't know if there's no questions. I think we can conclude.
Yeah.
Or any
So
comments from the audience?